Evaluating and managing circulatory failure is one of the most challenging tasks for critical care physicians. Thorough understanding of circulation and blood flow physiology is required for management of cardiovascular ICU patients. We have our next speaker as Dr. Bhumi Dave from Rajkot. Madam's topic for today is how I manage right ventricular failure in my ICU. Dr. Bhumi Dave is MD Internal Medicine from BJ Medical College, Ahmedabad, IDCCM Fortis, Mumbai, FCCM. She is consultant physician and intensivist guide for IDCCM. Presently, she is at Wockhardt Hospital, Rajkot, and her area of interest is mechanical ventilation, echocardiography, and peri-op management of high-risk cases. Madam, we welcome you. Please.
Thank you. Good morning, everyone. At the outset, I would like to thank Team Karamsat for inviting me here and wish them all the very best for the grand success of the conference. And it has been made very easy for me to talk on RV failure in ICU, as Dr. Rajesh Mishra has already covered the cardiogenic shock, the basic concept, the pathophysiology and the treatment part of overall cardiogenic shock. And I am going to stress upon the RV failure in ICU. So right heart failure can be defined by a clinical syndrome due to alteration of structure and or function of the right heart circulatory system, which is comprised from systemic veins up to the pulmonary capillaries, that reduces the ability to propel blood to pulmonary circuit and or high systemic venous pressures at rest or with effort. A failure of RV is a frequent component of right heart failure, but not a mandatory feature of the right heart failure syndrome. Acute RV dysfunction is defined as at least one of the following, that is acute occurrence of RV systolic dysfunction by measuring the longitudinal systolic displacement and dilatation, unexplained increase in the natriuretic peptides in the absence of left ventricle or renal disease, and ECG shows RV strain patterns with strong markers of moderate to RV strain. Acute cor pulmonale is a form of RV dysfunction due to an acute increase in the RV afterload. And acute RV failure is defined as acute right ventricular dysfunction plus low cardiac output and hypoperfusion with the consequent multi-organ dysfunction failure. So these are the definitions of acute right ventricular dysfunction, right ventricular failure, acute cor pulmonale. And there is again a definition which is there of the right ventricular dysfunction, in which there are echo parameters, ECG findings and biomarkers. Of the echo parameters, TAPSE is one of the most important part which we need to see when we are doing echo, and doing echo is a skillful job and we need expertise to diagnose TAPSE, and it is done by putting the M Doppler against the tricuspid valve. So that is TAPSE. If it is less than 16, it is the diagnostic of having right ventricular dysfunction. On echo parameters, there are various indices which shows there is RV dilation, ECG changes. We often get the ECG done in the ICU, and what we are supposed to see is the complete right bundle branch block, incomplete right bundle branch block, anteroseptal ST elevation, anteroseptal T inversion. So these are the things which we see in the ECG, and others are the biomarkers, that is BNP and NT-proBNP. So whenever there is the rise in the BNP and NT-proBNP which is not explained with the LV dysfunction, then we have to suspect there is right ventricular heart failure. So why it is critical? Why does RV failure have a poor outcome? Why we are concerned about treating and diagnosing RV failure in ICU? The reason is there will be decrease in the cardiac output, there is increase in the CVP, decreased blood pressure, increased pressure in the IVC and superior vena cava. Ultimately, it is going to cause decrease in the abdominal organ perfusion plus congestion, and decrease in the CNS perfusion, and it might end up with multiple organ dysfunction. And the pathophysiology, as already has been explained in the first lecture in the cardiogenic shock, again this is very much important to just go through what are the main components which will lead to RV dysfunction. So in RV dysfunction, there is an acute increase in the right ventricular afterload, which causes increase in the right ventricular pressure, which causes decrease in the transseptal gradient. There will be intraventricular shift, left RV global, RV becomes globular. So there will be decrease in the RV cardiac output. It will affect the decrease RV filling and decrease LV cardiac output, and ultimately it is going to lead to systemic hypotension. And more or less it is a vicious cycle. So when there is the systemic hypotension, again there will be increase in the LV and diastolic pressure, LV ischemia, and again it is going to cause the increase in RV pressure. There will be RV dilatation, there will be pericardial constraint. It will cause increase in the CVP, so there will be double hit rapid organ system failure. So this is the main area which we need to concentrate upon. This is what we see in the cross-sectional area of the RA and RV. This is the normal heart. See, the RV is very small, LV is muscular. But when there is right ventricular volume overload, this septum becomes flattened. RV is acutely dilated, there will be increased pericardial constraint, and the shape of the LV will become D-shaped from the circular one. So what are the common causes and differential diagnosis of acute right ventricular failure? So those are acute left ventricular failure, right ventricular ischemia or infarct, acute pulmonary embolism, chronic lung disease, acute lung injury with or ARDS, sepsis, pericardial disease, arrhythmias, congenital heart disease, vasculopathies, cardiomyopathies, and so on. But one or two are the most important one which we need to keep in mind when we are talking about the right ventricular dysfunction, and amongst them is the acute PE, that is acute pulmonary embolism, is the common cause of acute RV dysfunction or RV failure due to an excessive increase in afterload, that is secondary to obstruction by clots, vasoconstriction in a non-obstructed area, and intracardiac hemolysis resulting from the turbulent flow across the pulmonary valve. Echocardiographic finding in RVD is present in 30 to 56% of normotensive patients with PE, and normal RV cannot acutely overcome systolic pulmonary arterial pressure more than 50 millimeter of mercury. So this we need to keep in mind. Then comes the ARDS. The incidence of acute RV dysfunction in ARDS is nearly 30 to 56%. Both pulmonary hypertension and RV contractile impairment are main factors in RV dysfunction. The predictors of acute RV dysfunction in ARDS are, that is pneumonia induced by ARDS, PA-FiO2 ratio less than 150 millimeter of mercury, PCA2 more than 48, and driving pressure more than 18 millimeter of mercury. So, routine echocardiography is recommended in all ARDS patients as the incidence of RV dysfunction is more than equal to 20%, allowing early implementation of RV protective strategy that might prevent RV dysfunction. So these two are the most common things which we see in ICU as the cause of RV dysfunction. Now, what will be the clinical signs and what are the biomarkers of acute right ventricular failure? So the common clinical signs are hypoxemia, signs of systemic congestion, increase in JVP, there will be peripheral edema, pericardial effusion, congestive hepatosplenomegaly, ascites, anasarca. There will be signs of right ventricular dysfunction, paradoxical pulse, low cardiac output state, hypotension, tachycardia, cold extremities, central venous abnormalities, oliguria. And the biomarkers which we get it done routinely are there we can see increase in the lactate levels, there will be increase in the BNP or the anti-pro-BNP levels, elevated cardiac troponin I or T, abnormal liver biochemistry or renal function test, and increase in the D-dimer level. So how to diagnose it? To diagnose what matters is the echocardiography. The ascendance of intensivist conducted echo has become important not only for early detecting RV dysfunction in ICU but also for monitoring and guiding a rational therapy to prevent RVF from occurring. So here lies the importance of echo, and now it has been mandatory and should and each and every intensivist should learn echo to do bedside echo in the ICU so that we can diagnose such abnormalities early, and if we pick up them early we will be able to treat them in a proper fashion. So echocardiography, that is transtracheal, at times if required transesophageal also has to be done, and what parameters we are supposed to see is the RV structural, functional parameters and RV afterload assessment. Pulmonary artery catheter is no longer used now, but still it has a role in RV dysfunction. So once we have diagnosed how to manage such patients, it is a tabular and a systematic approach how to treat such patients. So there comes you have to treat the triggering factors such as infection, arrhythmias, PE. You have to optimize the fluid status. You need to reduce the RV afterload by the pulmonary vasodilators. You need to optimize the cardiac output with the ionotropic support, and optimize the blood pressure by the vasopressors. If all this is not helping us, then we need to go for awake ECMO or other ECLS devices as bridge to transplant or until recovery, and we need to continue with the best supportive care. These are the few things where there is a specific treatment available, as in right ventricular infarct. You can go for early myocardial reperfusion in the form of percutaneous coronary intervention or systemic thrombolysis. For PE, there is systemic anticoagulation, systemic or catheter-directed thrombolysis and embolectomy. For decompensated pulmonary arterial hypertension, parenteral prostanoids are available with or without inhaled pulmonary vasodilators. And nowadays the studies stress upon more use of inhaled pulmonary vasodilators rather than the systemic ones. ARDS, we have to use RV protective lung strategy, that is limiting tidal volume and PEEP, avoiding hypoxia, hypercapnia and acidosis. For non-cardiac surgery, pulmonary vasodilators, myocardial reperfusion and inotropic drugs should be used. And for cardiac surgery, judicious use of diuretics, inotropic drugs, cardioversion and antiarrhythmic drugs should be done. This is the effect of volume on cardiac function in right-sided heart failure. So whenever we are resuscitating the patients or doing fluid resuscitation of patients having right-sided heart failure, we should know about the fluid responsiveness in this case. Because if the patient is having right ventricular dysfunction, and if you are going to give more fluid, you end up with increase in the right ventricular end diastolic pressure. There will be increase in tricuspid regurgitation, septal shift, decreased LV filling, and ultimately you will end up with decreased cardiac output and hypoperfusion of all the organs. So this patient should be fluid negative so that finally we will get increased cardiac output. These are the few class of drugs which are available for the treatment of pulmonary hypertension, and those are endothelin receptor antagonists, phosphodiesterase inhibitors, prostacyclin derivatives, and the newer ones are the guanylate cyclase simulators. So these are the class of drugs which are available. These are the pulmonary vasodilators which are used, and they are available in inhalational and oral forms. These endothelin receptor antagonists are available in oral and IV, and the prostacyclin derivatives are available in the inhalational forms. This Riosigate is the newer drug which is available right now. But of all these drugs, sildenafil, that is the phosphodiesterase inhibitors type 5, is the maximum used molecule. Now a word on mechanical ventilation in acute RV dysfunction. We have talked much about the ventilatory strategy in patients of treating ARDS, but this is few things we need to keep in mind when we are doing the ventilatory adjustments in the ICU. So that is the dominant RV effects of mechanical ventilation are to reduce preload and raise the afterload, which in setting of RV dysfunction may be a critical issue. So our aim is to control hypoxemia, hypercapnia, acidemia and respiratory airway pressure. So what we need to do is to limit the tidal volume and PEEP, thus limiting plateau pressures less than 27 centimeter of water and driving pressure should be less than 18 centimeter of water. We need to avoid hypercapnia of less than 60 millimeter of mercury and acidosis and preventing or reversing hypoxic pulmonary vasoconstriction. So in ARDS, the presence of RV dysfunction and not the PF ratio could be an indication for proning to unload the RV by recruiting collapsed alveoli without causing overdistension and reducing airway pressure in hypercapnia, what is called RV protective ventilation strategy. And one more thing we need to keep in mind is about the arrhythmias which occur in patients of right ventricular dysfunction. So right atrial contraction contributes up to 40% of RV filling and is more important when the RV compliance is impaired. So appropriate sinus rhythm and rate and the maintenance of AV synchrony and atrial kick can be among the simplest methods of maintaining and avoiding RV contractility impairment. So here electrical or pharmacological cardioversion for the restoration of sinus rhythm and the placement of a temporary pacemaker if heart block is present should be considered. So I would like to conclude my talk with whenever we are having a heart failure, what we need to do is the RV preload optimization, RV afterload reduction, treating the cause, RV contractile support and mechanical circulatory support. So these are the 5 things we need to keep in mind when we are treating right heart failure in the ICU. So I would like to conclude with that acute right ventricular dysfunction or acute right ventricular failure is seen with increasing frequency in the intensive care and causes or aggravates many common critical illness. Bedside echocardiography assessment and invasive hemodynamic monitoring remain the most valuable methods to diagnose and to guide a rational therapy of acute right ventricular dysfunction or failure in critically ill patients. So general precautionary measures, early diagnosis of RVD and etiologic specific therapy may reduce the appearance of right ventricular failure. Supportive therapy focused on improving RV function via optimization of preload, enhancing contractility and reducing afterload are the key principles in the management of right ventricular failure. Thank you.
So once again, a very good, excellent cover-up of the important topic by Dr. Bhumi.